Good morning. Today we are going to talk on the subject of parasites. Yes, there may be no symptoms at all. So most of the doctors will take it lightly. But I want to tell you that you can have a death due to parasites. And so many deaths can occur. The first parasite we are going to discuss is roundworms. And these roundworms, yes, there can be no symptoms at all. You can always have one or two roundworms in the tummy with no complaints at all. I take advantage of that, remember that. I'm a private practitioner. I do see, as I'll tell you later on, my every prescription carries a name of Zentel, which is for the worms, albendazole. So, every prescription. And I see patients who are very difficult to treat, neurotic, multiple complaints, giddiness, pain there, no sleep, no appetite, no constipation, whatnot. And I can't manage them, even on antipsychotic drugs. And then suddenly I find one of these patients coming to me and thanking me, Doctor, I must thank you, you're the first doctor who has cured me. And he has used the word cured. I'm confused, He said, you were right. I passed one big roundworm from the bottom. And that rascal was the cause of all my complaints. I am so happy. God helped me. That I gave as a routine prescription. And he thinks that worm was the cause of all his complaints. Because it's a horrible feeling. If you pass a worm from the bottom, big worm comes out. Or sometimes from the top. They can come as a vomit. Worm. It's a horrible feeling. So, I took advantage of this and I took the credit. Yes, I was suspecting that he had worms. I gave a tablet and he recovered, all the complaints disappeared. But at the same time, I should tell you, roundworms are very, very dangerous in children. Very dangerous in children. Because in children, it is not one or two worms. And those one or two worms, usually male worms, the stool examination is negative. They have got 40 worms, 50 worms, 100 worms, those children. And they can cause death. As you can see this, on the autopsy, I photographed this child who died of roundworms because of intestinal obstruction. And you see there was a perforation also. He also had perforation with peritonitis and he died. So roundworms in children, when they are in large quantity, they can, you see the length of them, see that, and they move around and they can enter any opening. They can enter the appendix, they can enter the common bile duct, they can enter the pancreatic duct, and all of them together can block your intestine, small intestine. With the result that any diagnosis of in children, small children, appendicitis, pancreatitis, cholecystitis, they all intestinal obstruction, perforation, they could be all due to roundworms. And you can save these children if you make a diagnosis. So your roundworm should not be taken very lightly. And you can have it in adults also, much less common. And of course, day by day, as I am practicing for the last 65 years, the incidence of roundworms is becoming less and less and less. And it will become zero. After my lecture, when I tell you, you can make it zero incidence in the population. But these worms are most famous for causing, when a small child is diagnosed as attacks of cough and asthma at night, when you diagnose in a small child, remember these worms can cause this. They're notorious for causing this. At night they migrate to the lungs and then they cause cough, they cause difficulty in breathing, asthma. So roundworms can cause number of complaints. Fortunately in adults they're very much less common, very much less common. Next, stool examination. Stool examination will not help you. It can show, of course it shows number of times over roundworm. But if there are one or two male roundworms, stool can be negative. Fortunately, now we have got a drug called as albendazole, 400 milligram tablet. This tablet has done so much good to our Indian population, you cannot imagine. You cannot imagine. One tablet taken, all the worms will be out, finished. So you're lucky, and I don't think you should experiment with old drugs which we used to give for roundworms and all that. Just give one tablet, and as I said, in my prescription, I always put one tablet of albendazole for every patient. Then we come to the other worms. Those are hookworms. Hookworms. See the variety of symptoms due to different worms. See the variety. Hookworms, the word hook, they've got something like a hook. And they stick in the duodenum. They stick to, they're like a small thread. They stick to the duodenum, and in the hook they suck the blood. So each worm will suck maybe 0.01 ml per day of the blood. But that is one worm. Suppose there are 300 worms. How much blood will they suck? So you can have patient who has got hundreds of worms inside, small, sticking to the duodenum. In the duodenum they cause duodenitis. Duodenitis will have symptoms of peptic ulcer syndrome, burning, pain, but not worth mentioning by the patient. Not worth mentioning. Neither can they see the worms in the stools that they will mention. And not only that, stool examination again is no good. You see, because suppose I get a patient, and suppose he is 62 years old, and I ask for stool examination, he says hookworm over present, pathology is right on. It doesn't help me, because he is 62 years old. He has got severe anemia. The presentation of these worms is not of the worms. Presentation is anemia of iron deficiency in a male patient. Why male patient? Because most of them are males, because these males, when they go into the fields without chappal, without shoes, these worms enter the body through the soles. With the result, in the cities you don't find hookworms. It all comes from the patients who are in their villages, towns, and they go in the fields. So that is why hookworm is a disease of rural areas. And the worms cause no problem at all, not even slight duodenitis, nothing. The presentation is of anemia. Anemia, iron deficiency anemia in a male patient, not acceptable. In a female patient, acceptable, because they can so often they misguide you about the amount of bleeding during the periods. In a male patient, there is no business. If you have got no bleeding piles, you can't have iron deficiency anemia. And if you do see a patient, that patient must be having hookworms. Must be having hookworms. And a single dose of albendazole can get rid of all these worms. Single dose, 400 milligrams. Hundreds of these worms can be killed in the duodenum. But the point is not that. The point is that this patient has come for severe anemia. In a male patient, the conjunctiva are white, the nails are white, the tongue is white. And when this anemia patient has got severe anemia in the conjunctiva, severe anemia in the tongue is white, and not only that, it's bald, like a marble, it's shining. White bald tongue means 100% iron deficiency anemia. You don't have to do any iron studies of serum iron, transferrin saturation, serum ferritin, not necessary. This is because normally I took out a tongue from in the autopsy, in one of the patients, I told them to remove the tongue. Give it to me, I photograph for teaching purposes. And what did I find? The tongue is not smooth normally. It's not like a marble. The tongue is like that earth which you are walking on the road, rough. It's rough. These are called as papillae. We call them papillae. And this papillae can get coating. When you eat food, some of the food will be sticking there. Or at night time, if you sleep with mouth open, the tongue can get coated. But the point is, the tongue is not smooth. If the tongue is smooth and it becomes like a marble, it's an abnormal tongue. And if it is white, it's iron deficiency, 100%. And there is one more sign we have got, which is the best sign in allopathic medicine, according to me. And you show me this one sign, I'll make a diagnosis. The nails become concave, either flat or concave. Concave means you can put drops of water. So often I see how many drops I can put there. I could put 4 drops of water in this nail. They'll stay. We call it koilonychia. You show me this one patient like that, and they're pale, absolutely nails are pale. Diagnosis 100% severe iron deficiency due to hookworms. Finish. Nothing else can cause this. Don't depend on the stool examination. You see, when we do stool examination, I was telling you, this 62 years old patient came and they reported hookworm. Now, in my mind, I'm not sure. Can he have a malignancy which is causing, he's 62 years old. So then, if that is so, then I like to know the count, the total ova count. So you tell your pathologist that we want the total count. If the total count is very high, he has got hundreds of worms. But if the total count comes to just 40, 50, then you have to look for a second cause of iron deficiency. So, hookworms have no presentation as worms. Hookworms have to be thought in a patient of severe iron deficiency anemia, in a male patient, and when the nails become flat or concave. The nails become concave. So here that means you have to treat anemia. I have seen patients coming with 2 grams, 3 grams hemoglobin, 3 grams, 2 grams in a high class society, patient will be dead. Patient won't be able to walk. Patient won't be able to go to the office. But you'll be surprised. These people can walk around with 2-3 grams. Although it is not safe, heart can enlarge. And today we have got intravenous iron preparations. And believe me, they are quite safe. See, in the past, the intravenous iron preparations were not safe. You give intravenous iron, patient gets convulsion. This patient will never come again. He will never come back to you. You are giving some drug which is causing. Today, intravenous iron is very safe. And if you give them intravenous iron, within 2-3 weeks, the iron comes up to 5-6 grams. And within 2-3 months, normal hemoglobin. That is hookworms. So, with no abdominal complaints, except mild duodenitis, most of them don't complain of it. And then we come to another worm. If you have got Muslim population, very important, who eat beef, those doctors, those of you who have got Muslim population who eat beef, this is the worm you have to remember. This is the worm you must remember. This is called as tapeworm because it's like a tape. And it is so long. It is flat. It could be 5 feet long, 6 feet long, 7 feet long. But you can't see it easily. You can't see by any imaging. It folds itself. It folds itself. It lies somewhere in the intestines. Tapeworm can be very long, but it is made of segments. You have to remember that. See, in these segments, 1, 2, 3, 4. These are called segments. So the tapeworm is a combination of these segments which are attached to each other. And you see what God has done. It's so interesting that each one of these segments, what we call, is normal. I mean, it's like a normal worm. It has got its own, it can walk, it can crawl. That is the beauty of this worm. And no sonography, no CT scan, nothing can show this worm. Stool examination, never. I'm telling you. Stool examination will be always negative. But the patient has got complaints, which the doctor doesn't want to listen, which you don't want to register. He says sometimes some patients can see these worms, these segments passing in the stool, but most of the times no. What the patient complains is that, doctor, something comes out from the anus. Now, if something comes out from the anus and goes on the buttocks, you will feel very uncomfortable. That means what? You are incontinence. That means you are old, you have no control on your sphincter. Look at the anal sphincter, how tight it is. Normally it's supposed to be tight, so no stool should come out unless you want. But if something comes out when you don't want, that is something to be thought of. So these segments, each segment, broken segment, comes out from the anus and then it starts walking, crawling. So it can crawl there into the buttock, it can crawl down here in the thighs. So, and which patient? Muslim patient. Muslim patient. I have seen in my life 2 Hindu patients having this, but then those 2 Hindu patients used to eat food in the restaurants. They were non-vegetarians. So in the small towns, in the non-veg food, they give you beef. It's cheaper to them. So they'll cheat. You can't make out in the taste. But otherwise, it is a disease of Muslim patients. And Muslim patients pray 3 times a day, 5 times a day. Some of them, of course, pray once a week. That's not the point. The point is, if you are praying and if something comes out, they stop praying, you have to do it again. You have to pray again. But when you're talking in your shop, when you're talking in your business, and then something comes out and is crawling there, and it's crawling, it's not like a stool, little stool comes out and remains there, sticking. No, it's crawling. Your attention cannot be focused on what you're talking. Your whole attention goes there. In short, these patients become miserable. They go to the doctors, every doctor, stool examination, normal. Oh, they'll give albendazole or something or some, nothing happens. Nothing happens. I've seen people, as I'll show you this patient of mine, that Pathan patient, they wanted to commit suicide. They thought their body has got some ghost which goes there around the buttocks. They can't even do namaz. So I had this Pathan patient. And the poor fellow, Pathan are difficult patients. I have written 3 articles on Pathans. Every community I have written articles. Each community has got a different type of complaints, depending on their diet, alcohol habits, tobacco habits, gutka habits, and lack of exercise, whatever it is. And I've written in the Pathan patient, first of all, very difficult to obtain history from a Pathan patient. Very difficult. History taking. You may be very good. You can't elicit out of this Pathan patient. Moment you ask the Pathan, कि लाला तुमको क्या तकलीफ क्या है? हमको तकलीफ क्या है? डॉक्टर तुम हैं, हमको क्या मालूम हमको क्या है? तुम बताओ क्या है? Now, this is the answer they give. How will you get the history out of them? No. So only by leading question. Leading question. भूख लगती है, संडास होता है, पेशाब होता है, नींद आती है. Like that. So anyhow, this Pathan patient of mine came and he was passing this segment. Gone to a number of doctors. Ultimately, he wanted to commit suicide. His friends told them, don't go to O.P. Kapoor. You will be alright. And he will make you alright. He heard the name. He came to my clinic. And then he told me, हमको आप अच्छा नहीं करेगा तो हम खुद कुछ ही करेगा. And I will commit suicide. I heard the story. I had made a diagnosis in 1 second only. There was nothing, no test required. And I know I'll succeed. I'll bring out the whole damn mum outside. But I told that Pathan, my lectures are going on. There are 1,000 doctors attending my lectures. So I said, see, Lala, मैं तुमको दवाई दूंगा. दवाई लोगे? हाँ, ये गोली दूंगा. वो अक्खा तुम्हारा कीड़ा, इतना लंबा कीड़ा 5-6 फुट का, बाहर आ जाएगा सुबह संडास में. तुम खाली एक काम कहूँगा, हमको प्रॉमिस करो कि वो उसको तुम डब्बे में डाल के, हमारा लेक्चर चल रहा है बिरला हॉल में, 1000 डॉक्टर आ रहे हैं, मैं उनको बताना चाहता हूँ कि देखो कि ये डॉक्टर, ये सब डॉक्टर ने बोला कुछ नहीं है, देखो 6 फुट का कीड़ा उसके पेट में था. जरूर करूँगा. So next day was my lecture and this Pathan took a tablet. In the morning the whole worm came out, 6 foot worm. I was lecturing and I keep 1 hour to show patients. One of the patients was Ali Khan. So I told my secretary, Ali Khan go here. So Ali Khan came. There was no box in his hand. I was shocked. How did this tablet did not work? And then he came like this. Pathan walked like this, not like this, as if he had committed some crime. So I told Ali Khan, क्या हुआ? वो कीड़ा गोली खाया? हाँ. कीड़ा निकला? हाँ. तो किधर है कीड़ा? दिखाने का. देखो ये डॉक्टर बैठे. डॉक्टर साहब माफ करो, हमको इतना गुस्सा था, हमने उसके ऊपर पेट्रोल डाल के जला दिया उसको. माफ करो. So the whole crowd started clapping. So he saw everybody clapping. So he became straight. Instead of doing like this, he became straight. So I told him, दादा फिक्र मत करो, दूसरा पेशेंट दिखाएगा ये लोगों को. And then he embraced me on the stage. आपकी इतनी लंबी उम्र हो, खुदा आपकी लंबी उम्र हो. From next day, my Pathan patients doubled. It's a small community, but one patient like that can increase your practice. That's called tapeworm. Tapeworm coming from beef. There is another tapeworm also which comes from the pork. Stool examination does not show tapeworm. Niclosamide is a drug, 2 grams, single dose. After 2 hours you give a little purgative, saline purgative. Next day the whole worm will come out. Finish. This is a pig worm, from the pigs you get. So for 20 years in medical college I taught wrongly. I used to say if you eat pig's meat, you get cysticercosis. If you eat beef, you get tapeworm. I was wrong. Cysticercosis is the name in the brain. You get those worms in the brain, in the worms. They say they calcify. Formerly they used to operate and remove them. Then some of the new worms will come. It was difficult. Very rarely, of course, if they cause hydrocephalus, one had to operate. Then we realized that these worms come from the vegetables. In my practice, I must have treated dozens of cysticercosis. 95% were Jain patients, vegetarian patients. Why? Because when there are pigs, when they pass stool, and if the soil gets contaminated with the ova of this worm, tapeworm, pig tapeworm, that soiled vegetables when you eat, they go in the tummy, they become cysticercosis. It's a disease, so it's a universal disease. It's in vegetarians, non-vegetarians, everybody. You can get, it all depends on sanitation. How good you are in cleaning the vegetables, boiling the vegetables. But these worms, they can go into the muscles, even in the pigs. If you eat pig's meat with the muscles, it has got cysticercosis. In the muscle, they are like small swellings, hard. They don't cause much pain, but they go in the brain, and in the brain they cause fits. So epileptic fits. So a grown-up man or a woman, first time if she gets a epileptic fit, the first diagnosis is cysticercosis. In the past, it was difficult for us to diagnose. Even when MRI came, initially we had some problem. Query cysticercosis, query tuberculomas. Tuberculosis is the second commonest brain disease. These are much more common than tumors of the brain. But now, for the last many years, they can identify beautifully in the MRI cysticercosis. And when you do diagnose, the treatment is very simple. The treatment is give albendazole, but not one tablet. Not one tablet. 2 tablets per day for 3 weeks. That will make about 40-50 tablets. So you go to you write down the prescription. The patient goes to the chemist. देखो ये गोली है हमको 40 गोली दो. He starts looking at the patient because they sell only one tablet. Every patient comes and takes 1 tablet. डॉक्टर कौन सा है तुम्हारा? पागल है जाओ डॉक्टर. क्या लिखे 40 गोली? पागल है तुम? Then he has to tell him, keep quiet. You don't know what is my disease, and I have to take this tablet for 3 weeks, twice a day. Unfortunately, you see what happens, this happens in all diseases. When you kill this cysticercosis in the brain, there is a lot of reaction, there is a lot of edema, and these people, the fits increase. They are surprised. They came to the doctor for 1 fit and now he is getting so many fits. So if you want to avoid this, it can be avoided 100%. Always put them on anti-epileptic drugs for a few months, 3-4 months. With steroids, because steroids prevent the reaction. So when you give them any anti-epileptic drug, see, you should not be afraid of prescribing these drugs. Because in epilepsy, we give these drugs for how many years? We used to say 5 years, then we said 10 years, then we said 20 years. Now people are talking about lifetime. Epilepsy is a very dirty disease. And I've seen patients taking for 20, 30 years, then stopping, then again getting the fit. Here it's not like that. Here you're going to give only for 3 weeks and finish. The patient is cured. This is pig tapeworm. Presentation of a pig tapeworm. They don't talk about anything in the tummy, stools, pain. Then we talk about another worm. Universal, worldwide. Threadworms. And these threadworms are very thin, I tell you, you doctors, most of you are older people, you need to wear reading glasses when you are talking about threadworm patient. Reading glasses. Otherwise you are going to miss, because the stool examination doesn't help. And the only complaint of threadworm is that the patient is putting his hand in the back and itching, perianal itching. And everybody is shy of scratching in that area, especially if you are standing on the bus stop, you are traveling, and if you scratch there in the anus, embarrassing. Embarrassing, especially for a woman. So imagine, so the only complaint of this worm, although it's a worm, we are discussing worms, is perianal itching, scratching. And these ova of these worms, which are in the intestine, are missed in the stool. You don't get them stool. Most of the time stool examination, you can see the stool examination we are doing in all these worms and all, most of them is useless. And they give a report of what? Some 25 headings. Stool, hard. It has to be hard because it's brought in a bottle. No? Then smell, foul smell. It has to be bad smell. How can stool have good smell? So all the useless findings they write in the stool. But what we are looking for, worms, very difficult. So you use a sellotape method. If in the early morning, usually very often in children this disease, small children. So small children, you look at the perianal area, early morning, put on your reading glasses and see, you might see this small, this is like thread. No, it's very interesting. The threadworms, they live like we have got dharavi, especially their dharavi is the colon. Which colon? Left colon, splenic flexor. In that colon, they all live there. And the female threadworms, they crawl in the colon at night, always at night. And they come out here. They come to this area. And here they deposit eggs. Now, these eggs, if somebody eats, he will develop threadworms again. So, very often these worms cannot be seen also, even with your reading glasses. So, you put a sellotape there. Put a sellotape at night. And in the morning, remove the sellotape and send it to the pathologist. He will see threadworm over easily. Threadworm also, or albendazole is a magic tablet, magic. You give one tablet of 400 milligram and all the threadworm disappear. But they again reappear. Why? Because the treatment of threadworm is more important than the tablet, is something else. That you have to treat the whole family. You see, treatment if one child means rest of the family must be having. May not be itching, may not be scratching. You see, a small child who has got this threadworm, early in the morning, he is good to go to school, so mother brings him to the bathroom, then come on, do brushing, this, that. In between, he is scratching the bottom, his anus, in between. And then he is washing the mouth. So his ova have gone in his mouth now, child's mouth, in the morning, early morning. So when the mother finishes this, then the mother will kiss him. Very good, baby. Come on. Now mother has got the ova in her mouth. By the time child, Mary, who is looking after that, she is dressing up the child. So mother is telling Mary, hurry up. The school bus is going to come within 5 minutes. You take the child and wait in the school bus. So Mary is ready to take the child. In the meanwhile, the husband, by the time he is dressing up, he is ready. He is telling his wife, I'm going, bye-bye. I'm going, I'm in a hurry, I'm sorry. Now the husband has got in his mouth. By the time Mary takes the child, school bus does not come. 5 minutes, 10 minutes, it is late. Mary gets fed up. So they both sit down. She puts that thing, his school box and all, both sit. In the minute she starts talking to him, then Mary does, she kisses the child. Now Mary has got in her mouth. By the time the Mary comes back home, mummy is left, madam has left for her office. Who is in the house? Ramu, cook. So they only two together. Moment Mary comes, Ramu says, hey Mary, come on. Now Mary has got in his mouth. And now the Ramu has got in his mouth. So now what is the position? Position is in the house, father, mother, son, Mary, cook, everybody has got threadworms. So the secret of treatment of threadworm is to treat the whole family. And number two, of course, preventive measures. You know that he should not scratch. Actually, single dose of albendazole can wipe off threadworms, no question. But as I told you, the whole family has got. So each one reinfects again. Reinfects again. You should repeat after 2 weeks again. And all family members, all the maids, all the servants, and the fingernails should be cut. Because from there the ova come. Wash the hands before the meals. Even the clothing of the bed sheets, etc., they should be washed every day. So each worm has got a different presentation. Worms does not mean, layman thinks, worms mean पेट में तकलीफ होना मांगता है. मतलब हमको तो कोई तकलीफ नहीं पेट में. हमको कोई, no. Each worm has got a different symptom. We come to giardia. Giardia is again worldwide. Worldwide. You go abroad, you find a lot of giardia. Giardia can cause nothing. It may cause nothing. Remember that. It may be silent, but it can cause diarrhea. And giardia is known for explosive diarrhea. Prack, when the stool comes out, a lot of noise. And in between also, a lot of gases coming, bombarding. Severe giardia can be bad, but stool examination shows the cysts or the trophozoites. Most of the time they are right. The treatment is metronidazole, 400 milligram 3 times a day for 10 days. There are 2 drugs which have changed the whole, let's say 3 drugs, which have changed the whole gastroenterology. Your gastroenterology system illnesses in India are nearly wiped off by 3 drugs. Albendazole, number 1. Metronidazole, number 2. Flagyl, Metrogyl, all these drugs. These drugs, metronidazole is like albendazole. Multi-system, multi-treatment. Very effective. It's a beautiful drug. You give 400 milligram 3 times a day for 10 days, giardia is wiped off. So giardia is very difficult to treat. But what is difficult to treat is that patients who are neurotic, who ask for stool examination, they want to see, I've still got giardia, I took the treatment, did it go away this month? So I had this patient from Kashmir, Srinagar. He was one of the priests and top priests, means his followers were millionaires, very big followers, and they believed in him 100%. They used to look after his health. They used to take him to doctor. He had come to me also once for his heart and blood pressure, etc. He was very impressed. He was very happy. But now his problem was that he used to do routine examination, very fond of blood sugar, stool examination. And every time he did stool, it showed giardia, cysts of giardia. Then he'll go to the doctor. Doctor will say, you have got giardia. He had no complaints. Abdominal. Okay, take metronidazole. He took metronidazole. 10 days, repeated the stool. Stool was negative. After a few months, again he repeated the stool. Again giardia. Cysts of giardia. This priest was very conscious. He was very handsome, red, very good personality he had. So he was very conscious of his health. So he went to consultants. Several consultants saw him. Then they know giardia hai, it's a common thing, nothing. ऐसा होता है. But क्यों? Why every time again I get? So then one of his followers said, हम तुमको London लेके जाएगा. Harley Street, London is famous for specialist diagnosis. He took there, nothing, same thing. That again after 3 months, stool shows this. Then he remembered, कपूर को दिखाएंगे. चलो बम्बई जाएंगे, कपूर को दिखाएंगे. He came to me, so I said, what is your complaint? He says, the stool is not a complaint. What is your complaint? What are you suffering from? He said, nothing. Appetite good, very good. Stool good, very good. The only thing was stool. So I think you want to me to look after the stool. So I said, okay. I did general examination. I have to pretend to do whole examination. And then when I saw his nails, look at the nails, big nails. This is not his hand. He refused to show his hand and get photographed. He said, नहीं हमारा हाथ photograph नहीं हम बहुत श्रीनगर का. I said, देखो मैं स्टूडेंट लोगों को डॉक्टरों को हाथ दिखाऊंगा, मैं बोलूँगा मेरा हाथ है, तुम उनको कैसे मालूम पड़ेगा तुम्हारा हाथ है? नहीं 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 डॉक्टर साहब हमारा हाथ हम फोटो नहीं दिखाएगा आपको, फोटो नहीं. But so I've taken some other patient to show that big nails, when you find this little dust collects there, and these dusts are what? Ova of giardia. So you carry this and then you're eating food 3 times a day. Those ova go down, they become again giardia, again you pass ova. Simple. The treatment is to cut the nails. That's all. I told him. I said, मौलाना साहब आपको कोई दवाई की जरूरत नहीं है, आप नेल कटर ले जाइए, बिल्कुल हर हफ्ते नेल्स काट दीजिए और खाने के पहले अच्छी तरह हाथ धोने का. Finish. I got the news after a few months. Maulana Sahib is very happy. He sent you best wishes. This is the treatment for giardia. Then we come to amoebiasis. Our whole medicine was spoiled years back by specialists who diagnose chronic amoebiasis. And who is responsible for all this? Pathologists. You send a stool for examination. The commonest report they write down is cysts of entamoeba histolytica. Cysts of entamoeba histolytica. Entamoeba histolytica on stool examination is the cause of amoeba. That's the name of the worm, whatever we are talking about. It comes from the food, dirty food. So sanitation bad, from the street food, this food, your cook's not washing the hand. Sanitation, in short. E. histolytica is the name, and believe me, in India, nobody knows what does E. histolytica look like. Pathologists are bluffing because they've never seen, they don't know what is. You see, the E. histolytica is, the worm is like this. Here. You know, and it looks like a kachra in the stool. Little, sometimes red blood cells are there, they're not impressive. They call this entamoeba histolytica. Wrong. Because anything can look like this in the stool. The entamoeba histolytica is diagnosed by the movements, not by the shape. It dances. It dances. Entamoeba histolytica is dancing continuously. Continue dancing. That dancing tells you this is entamoeba histolytica. And this is by dancing movement, it enters the mucosa, causes ulcers, causes dysentery. And the blood test, not for intestinal amoebiasis. Blood test for amoebiasis, formerly we had indirect hemagglutination test, IHA test. Nowadays there is usual ELISA test. They are not for colon biopsy, they are for liver amoebiasis, amoebic abscess. So they are negative. So there is no method of diagnosing. The pathologists don't know what is entamoeba histolytica. So how will you diagnose entamoeba histolytica? I've done so much studies on that it should be warm stool, like dal. You eat dal which is cold, there is no taste. Warm dal taste. The stool which you examine should also be warm like dal. And how will you get that stool? We had a laboratory in Bombay where the princes used to go for stool examination. That lovely method that you pass stool, immediately collect, and you can't do it in public, this test. Best thing is, everybody knows what is a swab test. Now that corona came, what is a swab? You want a stool sample, you want a fresh sample, you want a warm sample. Go to the bed of the patient, put your microscope there, next to him. Take a swab, put it in the rectum. What comes out is stool. Not biryani which he has eaten. It comes out, what comes out is your fresh stool. Now that you put immediately in the microscope, you will see the dancing beautifully. It's so nice to see them dancing, these Entamoeba histolytica. So that is, when that is found in the stool, that is amoebic dysentery. If the cysts are formed, that is nothing. People go on treating, because see, that's because the entamoeba has got so many types of entamoeba. One of the types of entamoeba is histolytica, and the cysts of all of them look same, and all of the others are benign. They don't cause any trouble. So cysts have got no meaning at all. But you give metronidazole and the 800 milligram 3 times a day for 10 days, or even 1 week. The response is beautiful. The only trouble is, what should a GP knows about entamoeba histolytica? Amoebic dysentery. In the past, everything was caused as amoebic dysentery. Moment the patient says, I'm passing blood and mucus. Blood and mucus is more important than blood. Huh? Mucus, sticky substance. The moment you ask them, they say, oh, chikra. Tell them to bring the stool. This is a stool of amoebic dysentery. Blood and mucus. Where is the blood? Where is the blood? And first of all, where is the stool? I can't see any stool. All I can see is mucus, and spots of blood. Spots of blood. This is amoebic dysentery stool. Moment the patient says, and you can't see it like this, and he's passing blood and mucus, the diagnosis is straightforward. For a GP, 100% I'll tell you, it is ulcerative colitis. See, ulcerative colitis is a very dirty disease. It's like we used to have amoebiasis in the past in India. This is ulcerative colitis in foreign countries. In UK, America, very common, and it affects what? All young people, young men, young women. What is the complaint? Passing blood and mucus in the stool. And I am telling you today, you remember me. In your lifetime, if you get a patient who complains of passing blood and mucus, solid blood and mucus, the diagnosis is ulcerative colitis. That's the name of the disease. Ulcerative colitis. Dirty disease. And believe me, for GP it's very easy to diagnose. Why? Moment that patient passes little blood, he goes to some doctor, everybody gets better, flagyl, metrogyl is being given by every GP. He's come to you after that, after taking those tablets. He's still passing blood and mucus. Diagnosis is ulcerative colitis. Finish. You will remember me. If you ever see the patient, then you send him for colonoscopy to a gastroenterologist. Don't treat ulcerative colitis. It's a lifelong disease, and you get remissions, and exacerbations. That means disease goes to sleep for a few months or few years, again comes back. Let the gastroenterologist treat them. The treatment is a large dose of steroids per rectum, steroids by mouth, with side effects and all you have to face. Don't treat them. Send them to a gastroenterologist for colonoscopy. 25-30 years back, a girl was brought to me, 22 years old, and she passed blood and mucus in the stool. She went to a gastroenterologist, who said, no need to do colonoscopy also, this is amoebic dysentery. Treated her for amoebic dysentery, no relief. They came to me. I was not a gastroenterologist. Moment they complained, I told them, I don't want to see this patient. This is ulcerative colitis. Gastroenterologist may be anything, I don't care. This is ulcerative colitis. So then they said, but Dr. Sahab, अभी तो एक दो दिन में तो वो अच्छी हो गई है. अभी संडास बंद हो गया है, खून बंद हो गया है. I said, it will one day come back again. It's a dirty disease. Anyhow, the parents were not happy with me. Because I was very blunt, because this is a dirty disease. I don't want to take anything. The time went on 6 months, 1 year. She got married. They got her married. After 1 year, when they got married, they went for honeymoon to America. The husband took her to America, and then she had an attack. We call it an attack of remission, means exacerbation of ulcerative colitis. She was passing blood and mucus, dozens of stools, dehydrated, this thing, admitted in the hospital. But they had no insurance. In America, you have no insurance. That man spent 3 lakhs rupees in the hospital. 3 lakhs rupees. And then what? Came back to Bombay, divorced her. Divorced her. He said that the parents were hiding this illness. They fooled me, cheated me. This is a story of ulcerative colitis. Please don't diagnose amoebic colitis anymore. It is not. It will be very, and if it will be there, it will be like this. Mucus, this, and metronidazole you give 10 days, 100% cure. 100% cure. I am talking all this based on my experience. If you see amoebiasis in private practice, it will be liver amoebiasis. Liver amoebiasis. That in the liver, this is, God was kind to make me think. I was like doing cardiology, physician and heart specialist. But I thought of going to autopsy room. I took sabbatical leave from the government for 1 year. And then I was doing autopsies. And can you believe, I mean, I can't believe myself, you know. I was doing autopsies on the tables in the autopsy room. You know, autopsy room in JJ Hospital, Grand Medical College. Huge hall. There are 10 tables, long, 6, 8 feet, all marble table. And what marble? That marble is ever shining green, nothing breaks. I come from Grand Medical College. Grand Medical College was the first college in India, 1848, which started. And who was the physician there? Charles Moorhead was English doctor. He was the physician and the dean of the medical college. But he was a very interesting man. He was very fond of learning. And then this man, although he was a dean, he was a medical, he used to go to the autopsy room. If somebody died in the hospital, he'll go, how did he die? He'll go there in this, the same room where I have done this thing, worked for 1 year. He used to go to the same room, same table. Charles Moorhead was his name. Charles Moorhead. And he is the one who described the first case of amoebic liver abscess in that, on that table, Grand Medical College, 1848. He described an abscess, and he said this abscess is due to amoebiasis. Later on, he was very busy. He has not done much work on that. And later on, years passed. And after 145 years, O.P. Kapoor goes to the same autopsy room and starts doing. I went just to study. See, I thought by seeing autopsies, my medical knowledge will become good. And what did I find? On the second, third day, by the time in the autopsies, every alternate days, one patient used to die of amoebic abscess. One patient. I heard this. I was shocked. I said, this is bad. Something should be done to make the diagnosis better. And that was the time there was no sonography machine. There was no sonography. And even flagyl had not come. It was there in the Europe only. Metronidazole in the name of flagyl. So, alternate days patient dying of amoebic abscess. When I saw this patient, this is the liver, and here is an abscess in the liver, left lobe, and this has ruptured in the lung, in the heart, and you can see in the heart the whole pus here, pericardial tamponade, when the heart could not contract anymore, and the patient died. The abscess killed the patient through the heart. This abscess, if it was here, it can rupture anywhere. If it was here, it will rupture in the lung and kill. If it is here, it will rupture in the peritoneal cavity and kill the patient. I was very interested. I said, I am a cardiologist. This is one of the heart problems. but it comes from the liver and it comes from amoebic abscess. But amoebic abscess, every alternate day autopsy. So I started collecting all these patients. I said, I am going to write a book on amoebiasis, because so much material, who will get it? Nowhere in no part of the world you can get so much material. And I collected more than 200 cases of amoebic abscess in the liver and solved many problems, and especially of chronic amoebiasis, in the sense that in our autopsy room, one side is our autopsies of medical, on the other side is medico-legal autopsy. So all accident patients, motor car, they're dying, they're all on this side. So there is normal population. So I became very friendly with the coroner of Bombay. He was impressed by me. I used to come in on my flashy suit and Mercedes car and my stethoscope, my camera. And he said he has never seen a doctor coming like this, medical. So I told him, will you allow me to take colons of all your patients, all your people whom you do autopsy? He allowed me. So I have studied 100 colons of normal people and multiple autopsies and biopsies my students took there. No amoeba, nothing like chronic amoebiasis. And not only that, all these amoebic abscess patients, when we saw the colons, 95% had no colon amoebiasis. No colon. So much so, in my mind, I started thinking, there may be another entamoeba histolytic of one going to the colon, one going to the liver. And liver, it can go anywhere. Of course, patients who are a little alcoholics, maybe a little more incidence. But the fact is that this book it weighs half kilo. So heavy book. And this was my work of 200 patients, where I showed, because there was no sonography at that time. The flagyl metronidazole had just come, not even available in Bombay much. And I showed how to diagnose clinically a patient having amoebic abscess, left lobe abscess, superior surface abscess, which can cause pain in the right shoulder, which was described in the books, inferior surface abscess, which ruptures and goes to the surgeons as acute abdomen. Everything I described. And then what happened? I said, metronidazole had come, Mr. Powell had invented. So Powell became a hero in the world. Powell started traveling all over the world. And because he had invented metronidazole, and he wanted to come to India, he heard of my book, that O.P. Kapoor, somebody is writing of amoebic liver abscess. No gastroenterologist has ever written in the world on this subject. Everybody writes about intestinal amoebiasis. He was very keen to meet me. And when he came to Bombay, he was searching for that. I want that gastroenterologist, O.P. Kapoor. No gastroenterologist, O.P. Then he said, O.P. Kapoor, yes, there is one cardiologist. When he met me, he was very keen to know that you have published 200 patients of amoebiasis, more than 200. Did any of them take metronidazole, my drug, and then die? This is the information he wanted from me. I said, yes. How many? I said, around 20. Then I took him to my house and I showed him about 200 slides. Then I showed him. I said, Mr. Powell, those patients did not die because they did not respond to metronidazole. They die because of the wrong diagnosis. Because by the time sonography had not come to Bombay, we had no sonography machine. It is the early 70s I am talking about. So, patient like this, for example, was diagnosed as amoebic liver abscess of the inferior surface. It had ruptured. So the surgeon opened up. Surgeon drained it. You can't say drainage was wrong. He removed all the pus. And after 2 weeks, this patient died. How did he die? Because there was a second abscess sitting there on the superior surface. And we had no sonography. We had no photograph. X-ray cannot show liver. Nothing can show you liver except sonography and CT scan. They were not there those days. So I said this was missed. And in my book, I have explained, anybody who is abscess, first find out is it 1 or is it 2, and if superior surface abscess, right dome of the diaphragm will help you. Inferior surface abscess, palpation, proper palpation will help you. He was very happy. I said, these people received metronidazole, even then he died because of the wrong diagnosis. The second abscess was missed. So Charles Moorhead, who had done this first case in the world from our Grand Medical College from where I come, he had described. And that time he had described that the pus which comes out, which he removes, is anchovy sauce. Anchovy sauce is a pus, is a sauce which is very popular in London, England. So, and he was a British doctor. So naturally, he used the word anchovy sauce. And all the literature in the last 100 years, you see, amoebic liver abscess, pus, anchovy sauce, right? So I used to say, but nobody has seen anchovy sauce. Then how do you go on saying that this is anchovy sauce? I went to London. I flew there, bought a bottle of anchovy sauce and put it in the jars there. So every time I will remove the pus, I used to compare. Does it look like anchovy sauce? Does it look like anchovy sauce? Does it look? I used to compare. And I found it was wrong. The pus of amoebic abscess is usually brown because liver is brown. See, this is a basic brownish color. But it can be deep brown, reddish brown, it can be this, it can be yellow, it can be this. Any amount of pus can be amoebic liver abscess. You have to put a needle. If the patient does not respond within 2-3 days of metronidazole, you have to aspirate the pus. Don't wait for it to subside. Or patient might die by the time, and why should he suffer? In those days, hundreds of aspirations we have done. I must have done hundreds without any sonography. Put a needle, easiest thing in the world, and the pus comes out. Now, the modern GPs, you people are lucky. You're very lucky, because to diagnose amoebic liver abscess today, you need only sonography machine. That's all. And sonographer cannot miss it. Let me tell you that. He can wrongly diagnose maybe malignancy and not abscess. That malignancy is very rare of the liver. And today all GPs can treat amoebic liver abscess. All you have to do is 2-3 days patient doesn't respond, send it to a sonographer. Tell him to do tapping under sonography machine. Finish. Why should you send this patient to the specialist? You should not. So today, treating amoebic liver abscess has become a joke. If that is so, then of course I lost my hard work. The only thing in my life I would have got, the first book in the world. It is there in every library in the world. But no doctors are buying, nobody is reading it. Why? They don't need it. They don't need it. Because the moment you find the patient complains of fever and pain in the liver area, all you have to remember is liver area is in front, liver area is in the lateral, liver area is behind, liver area. Pain in the liver area, fever means amoebic liver abscess. Finished. Maybe small abscess, big abscess, and then if you examine him, this is the test for all GPs should do. Moment he says liver area, do like this. Moment, oh, he says, oh, finish. The diagnosis is over. Amoebic liver abscess. You can press like this also, liver, and then he doesn't improve within 1 or 2-3 days. Then where should you put the needle? This is the way to find out. You put a finger in that area which is tender, and the most tender area in the finger, that is the place where you put a needle, pus will come out. Finish. Diagnosis is over, treatment is over. So, although we didn't earn anything, neither name nor money from this book, no gastroenterologist has sent me one patient in the last 30 years, 40 years of liver abscess. They all think, why should you send to? We all know it. Nothing to do. But two surgeons, cancer surgeons, have sent me in the last 10 years two patients. That Kapoor ko bhejo, he is specialized in amoebic liver abscess. I was surprised. What does a cancer surgeon want from me? The first patient, big area in the liver, sonography, and they thought it is amoebic liver abscess, or cancer of the liver. That I'll show you a little later on. And cancer of the liver, biopsy was done, and in the biopsy, the histopathologist reported entamoeba histolytica. Entamoeba histolytica reported in the biopsy. Nonsense. How could he see the movements there in the biopsy? That means he doesn't know what is entamoeba histolytica. He must have seen that shape, and he must have seen a few RBCs. I knew that the histopathologist had misguided them. I saw those patients, and then I wrote an article on this for GPs, that if you want to diagnose a cancer, or the relations ask you, doctor, are you sure this is not cancer? No. What will help you is this, the blood test. Cancer of the liver occurs only in people who have got a virus B or virus C. So if you have got a viral B test positive, HBsAg, if you have got anti-HCV test positive, that is viral C, and the cancer marker in the liver is alpha fetoprotein, if these three tests are positive, I don't want to see the picture of a sonography. I don't want to see the biopsy picture. That is cancer. That is cancer. Finish. If these three tests are negative, and if the serology test for amoebiasis, whatever ELISA test or any test, positive, and those three tests are negative, it's amoebic abscess. Whatever you might see, it may be solid, it may be liquid, it may be looking like this in the biopsy. Both the times in these patients, I have told them, I send the patient back, very sorry, it is not amoebic liver abscess, please continue your treatment for cancer. It's a cancer of the liver. That is about amoebiasis. There are some other worms which look like, all of them look like this, like threadworms again, most of them. One of them is strongyloides. Fortunately, it is not common, not like giardiasis. Giardiasis is common. They can have diarrhea, and then the stool sometimes shows, sometimes doesn't show. Then you have to do aspiration by endoscopic method from the jejunum. These are bad worms. They can cause a lot of trouble. So you can put an endoscope, aspirate, look for strongyloides. I do in my practice, barium meal of the first part of duodenum. That's the area from where I see if that area is dilated, that must be strongyloides. And you can give either ivermectin for 2 days, albendazole, both are available. But let me tell you, it's not a very common illness, but it's a bad illness. It's not as simple like giardia, amoebiasis, that. And again, one dose of albendazole or ivermectin, and the thing is gone. This Trichuris trichuria is another worm. Use it. Most of there are big names now. I'll show you. I'm not going to show you all the names. With the pathologists right to frighten you, GPs. Those are benign parasites. They don't produce any complaint at all. And if the diarrhea patient has got this, I'll still diagnose irritable bowel syndrome and not look at this. Although patient is not happy, doctor usko nikal do na sandas mein se. Okay, give albendazole. It will come out. It will get cleared. So this particular thing. So, in my opinion, you give deworming all your patients, twice a year, one tablet of albendazole, 400 milligram. One course of metronidazole. Today metronidazole has gone where? From the earth it has gone in the sky. The sales of it is useful for everything in the body. Physicians use it, surgeons use it, gynecologists use it, metronidazole, the skin specialists use it, obstetricians use it. Everybody is using metronidazole. Metronidazole. It has got multiple indications. But I am talking about routinely give it. Every year, twice a year. And then of course, I like to give typhoid vaccines. When you got, why shouldn't you give it? People who are travelling, going all outside Bombay, small villages, eating, they should get typhoid vaccine. So, and now you can see what has happened. In the last few years, the worms have become very rare. Compared to earlier, compared to earlier. We used to see so much worms when I started my practice 65 years back. Every week I would see only worms and metronidazole, amoebiasis those days. Amoebiasis has more or less, intestinal amoebiasis disappeared. But in the irritable colon patients who behave like amoebiasis, mucus in the stools, diarrhea, this drug, if you give, it gives them some relief for a few days. It does give, how, I don't know. I have written articles on this. I don't know how, but even in an irritable bowel syndrome. And it has got hardly any side effects. So you can give it to all patients of diarrhea with mucus. And then we come to lump in the liver. Here is a lump in the liver. What is it? You do sonography, you do CT scan, and then you can do laparoscopy here. And because here you can see, there you can see the naked eye cyst. And if it happens to hydrated cyst, it will have to be operated on. Now when you operate on hydrated cyst, you find these small cysts, bachus, small bachas there. If something falls outside or is not, they can again grow into big after 10 years, 5 years. So the albendazole works on these small things, but not on the big one where it have to be operated. So you give albendazole in hydrated cyst for 3 months after the surgery. 3 months after the surgery. So now, what is the position of albendazole in private practice? I use a single dose in every patient, prophylactic. And it is said by somebody, I cannot remember who has said it, that if you give albendazole like what I said, twice a year, they say that all the parasites will be eliminated in the next 20 years. You will not see any parasites. This has been quoted. So why not you take advantage of this? If you give the same albendazole for 3 days, strongyloides will be wiped off. The same albendazole for 3 weeks, not 3 days, 3 weeks, neurocysticercosis, which we discussed. And the same diagnosis for hydrated cyst, after the operation, you give this for 3 months. So single dose, 3 days, 3 weeks, 3 months, that is the beauty of albendazole. And finally, I want to show you some other parasites like candida of the tongue. It's very important. Why? Because if you see a child, an all malnourished child, very ill child, you see tongue is full of white. What is this white? This is candida thrush. It's treatable. You got candida lotion, you got ointment, you got cream, you got tablets, you got other itraconazole, other antifungal drugs. But the important thing is the diagnosis, that this child must be immunity must be very low. So therefore, if I see a white patch like that in a healthy man who has come to my clinic, what's any complaint, I'll suspect AIDS, HIV. HIV. Because HIV is the only condition where you can't see anything, no special sign, and the immunity is low down. CD4 count goes down. And the first thing will be fungus infection. and from the in the tongue. This you must learn. If you do find severe diabetic patient can have, and of course if you can't peel off this bite, then the EB virus. EB virus is rare. You don't have to know as a GP, I think. One more thing I want to tell you: angular stomatitis. This mistake I have seen being committed for years together. This patient has got angular stomatitis, means angles of the mouth. Angles of the mouth. You see this? See this? Only this, nothing else. Tongue is normal. Tongue is normal. Mouth is normal. And the doctors go on giving them B complex, B complex, and B complex for months together. They think it's B complex deficiency. B complex deficiency, tongue will be affected. Tongue will show red tongue, bald tongue. This is due to fungus again. Fungus, Candida. I remember one patient in my club, millionaire, and I used to see him in the washroom, in the gents' room, and I would see this. I used to get very irritated, Such a rich man, and I don't know him, I didn't know him. But one day I had to ask, excuse me, what are you taking for this? He said, B complex. I've taken plenty, but damn thing is not responding. I said, it is not B complex. I gave him the candid, the cream to apply and tablet. In 2 weeks it disappeared, and he was searching for me in the club. Who is that man? What is his name? Kapoor. Oh, I want to thank him. I want to thank him. Because people go on treating this with B complex. It is a fungus infection. It is not B complex. And then finally, one thing about herpes simplex. Herpes simplex is this. You see, moment this man had pneumonia fever, high fever, this appeared. The doctor said, oh, this is herpes simplex. This is known as herpes simplex. So I write down the treatment. There are a lot of drugs now for viruses. And he said, doctor, please don't. And they are all costly drugs. This will go. He knew this will go. Because he had got it previously also with fever. And same thing, there are some patients with every fever, everything. This lady here. Don't waste their money on antiviral drugs. They are called valacyclovir. Valacyclovir has come. Very costly. Yes, you want to use valacyclovir, everything. Use it for herpes zoster, not herpes simplex. And this patient, moment he starts having pain there, which I have discussed in the past, severe pain, he can't touch the skin. He is starting 2-3 vesicles enough. Start valacyclovir. And the illness will be halved, and chances of post-herpetic neuralgia will be reduced. Finally, one slide, now people are talking about black fungus, this fungus. These are not your illnesses, not for GPs. You don't have to learn. These are hospital illnesses. So consultants in the hospital, they should learn, not you. There is one fungus called aspergillosis. There are a lot of fungi, like black fungus and all. And this aspergillosis is a fungus. Again, aspergillosis can cause a fungus local illness. No, not common. But it can appear as an allergy to aspergillosis, as a resistant asthma. So if you remember when I discussed asthma, I discussed if a patient has got resistant asthma, doesn't respond to your inhalers, exclude what? Aspergillosis. Exclude vasculitis. And aspergillosis is known as allergic bronchopulmonary aspergillosis. You will suspect it from eosinophilia. Eosinophil count is very high. Very high. And then you ask for blood tests for Ig antibodies against aspergillosis. They will be strongly positive. And then you ask for HRCT scan of the lung, they will be abnormal. Make a diagnosis, push this patient to a specialist. Don't treat, although you can treat it and you can get a very good response. Treatment is of steroids. Large dose of steroids. You give them, this patient will respond. But how long to give? When to give? Best thing is don't take up such a patient. Refer this patient to a chest specialist, and that should be okay. Thank you.